Dr. Panjrath is next. He's the Director of Heart Failure and Mechanical Support at George Washington Heart and Vascular Institute in Washington, D.C. And he's going to talk about real-world experience with Barostim device.
Well, thank you. First thing, pardon my voice is not too much parting. It's not, anything active, just a lingering laryngitis. So bear with me on my voice there. I'll try to go slow. But, we heard about the unmet needs in heart failure, where there's a big window of opportunity. We heard about the BeAT-HF data now. Now, when you put it all together, where does all sit in your real-life practice? And I'm going to share our experience in our center of where this sits and what our experience has been.
I remember that, yeah.
So, for any therapy or device, a new device therapy, I think of it as the big five questions. What's the appropriate phenotype beyond clinical trial, inclusion and exclusion criteria? What's the appropriate timing of the device? How about prior authorization and reimbursement? I'm not going to go through that in this session just because of time. Then how do we, complement or pair it up with GDMT as well as diuretic titration, and specifically in case of Barostim? And then monitoring the response of is it really working in our patients and at what time points. So let's start with appropriate phenotype. I mean, these are the indications. These are the FDA labeling, NYHA class 3 or class 2, who had a recent history of class 3, despite being on guideline-directed medical therapies. And remember, this is both medications and devices, as we've seen in the BeAT-HF trial, 80% plus patients had ICDs in the trial as well. Now, and I'll come back to this a little more in terms of what other devices does it kind of impact. LVEF of less than equal to 35%, and then an NT-proBNP of less than 1,600. And this is important because, this is when it comes down to real practice and how do you decide that patient, based on biomarkers level, as Dr. Lindenfeld mentioned, response or persistently elevated biomarkers being a prognostic indicator, or those who respond to it, you can actually help use that as a tool in your toolbox to identify the appropriate patient. So who are the patients in real life practice? Let's start with, patients who have ICDs. Patients who have ICDs and despite being on GDMT and ICD, because remember, you're putting an ICD only when they're already on appropriate GDMT. So, if you already have a device in them, you're assuming the fact that you have an appropriate GDMT utilization in these patients, number one. So if they have still residual symptoms, think about those patients. How about CRT? Now, CRT itself, class 1 indication for CRT, you're not going to go in and put a Barostim in those. You're going to go for CRT because there's a good response rate in those. But now they have a CRT, and they are either partial responders or non-responders. That's another group of people you need to be looking at. And, obviously partner up with your electrophysiologist, optimize them as much as you can. I mean, there are all these tools now you can do to optimize them. But if despite that, they are exercise limited or have, poor quality of life, you want to consider those patients. Patients who are hospitalized for heart failure or are re-hospitalized for heart failure, despite being on therapy. I'm not talking about the de novo or the new diagnosis of heart failure. I'm talking about patients who already have a diagnosis and they are on therapy and they're coming back. Think about those patients as somebody who may benefit. And this is obviously very intuitive. Patients who are, have difficulty performing meaningful activities of life. But this becomes important because that's where you distinguish your class 1, class 2, class 3 patients. And, when they come for routine checkups in your practice and your clinics, this is where you use different tools to elicit those symptoms. And it's important that you don't forget that. Beyond those, there are also those patients, as we heard before, they are intolerant to medications. There's affordability issues. Hopefully 2025, some of the affordability issues may get a little better, especially as it relates to SGLT2 and ARNIs. But those are real, considerations in real life practice. And as we have seen in some of the data from BeAT-HF and other registries of what the actual utilization of medical therapy in real life practice is. The intolerance could be hyperkalemia, could be CKD, could be low blood pressure, and I'm going to come back to the low blood pressure aspect again in a second, and or other side effects. Or, as I said, it could be affordability. But all these, reasons for intolerance or lack of affordability, those are the patients, if they are symptomatic, you could think about complementing it with neuromodulation or Barostim activation. Now, this is data which you all know. Dr. Haywood also showed you the slide. We know that in real life, the data GDMT utilization is poor. At the time of initiation, there's a delay. This is from BeAT-HF. There's a delay beyond 3 months in terms of initiation of therapy, and when you follow up after a year, the rate of discontinuation is very high, and reaching a target dose as recommended by guidelines is pretty dismal as well. So again, these are real life issues, but we can kind of, along with addressing them, recognize that these are patients who could benefit from Barostim activation therapy. Now, just a quick point on intolerance. So when we talk about intolerance, not all phenotypes of intolerance are the same. You have to be very cognizant and have to kind of deep dive into phenotyping those patients a little bit, making sure these intolerant patients is not due to end-stage heart failure. You're not talking about class 4, because I think that's a segment which needs LVAD and transplant, or if they're not a candidate for either palliative care, that's a whole different segment. You're not intending to, implant devices in those patients. That's not what the strategy should be. Or somebody with severe autonomic dysfunction or systemic disorders which are causing, severe autonomic dysfunction. That's again a group of people you want to phenotype in those intolerant category and avoid those. So beyond identifying those patients, what's the appropriate timing of implanting these devices? And again, this is a life cycle of patients, especially progression of quality of life and other measures in heart failure patients. And this is especially applicable to partial responders or non-responders in my mind. Obviously, if they are responders or fully responders, or they have improvement in their LV function and symptoms, they wouldn't be in this category. They wouldn't be on this curve. So anything beyond that, they are on this curve. And as you can see, there's the initial phase, I would call it the phase 1, where initiation of GDMT and up titration. And there's a phase 3, which is where they progress beyond. That's the LVAD and transplant stage. And in between that is a big category. And that's where all these therapies, novel therapies, have a role. And that's what the window of opportunity is. These are patients who were class 2, class 3, previous class 3, now class 2. And, this is where we can really utilize this therapy. Now, the big question, which is not supported by clinical data right now, or not supported by clinical trial data, but, the question is, can this window be made wider? Can we move towards the left? Obviously, we don't have, we can all talk about clinical experience, but we don't have the data to support that. But that's something we can probably, if we have time in the debate session. Now, when I talk about that expanding the window, and this is something, a question, this is not again supported by clinical trial data, but we see that in clinical practice, we can start differentiating those who are responders or super responders and who are not the best response. My question, becomes is, if we wait till too late, are we just avoiding the progression of disease? Are we making this, this line in the red, are we right there, where we're delaying progression? Or if we go upfront or upstream on a timely recognition, timely initiation of this particular therapy, are we, can we change the trajectory of disease? Can we really show improvement? And that's something still needs to be kind of teased out. Now, for folks who are in the advanced heart failure centers, including people like for us, we get a lot of patients who are being evaluated for advanced therapies, or being referenced for me for that. So how do you kind of factor in the previous points I made, avoiding those patients who are too advanced? And you can use tools which you have in hand already. you have this data in your hand, because if you're an advanced heart failure center, most of us are using cardiopulmonary stress testing, we have hemodynamic data, and obviously we have biomarkers, as we have heard in previous talks. So you can utilize them and help make a more deep phenotype of this patient, and based on that come to which patients may benefit better. Now, when I talk about NT-proBNPs, I think more than an absolute number, to me, it's more important is, are they actually switching or changing? Is there any decrement in the NT-proBNP level based on some of the therapies as you initiate? And that just tells you a little bit about how to project about whether the response is going to be or not. This is a proposed algorithm what we use in our practice, and I think some other advanced heart failure centers use it as well, and maybe you'll hear in the next talk. And this is how we incorporate our hemodynamic as well as cardiopulmonary stress testing data. We look at their VO2s, and then we combine them based on where they fall with our cardiac output index data, and based on that, we decide whether we go, if they're too far advanced, they go for LVAD and transplant, or if not, then we consider them for Barostim implantation. Now, that's kind of all about phenotyping and timing. What about once they have an implant, what do we do? This is our algorithm or titration protocol, similar to the trial itself and other centers. At the time of implant, once we have implant, we do hold beta blockers and ARNIs at the time, just to kind of avoid any confounder in terms of blood pressure from the anesthesia and other things. And then we rapidly titrate them. We titrate them over the next 9 weeks. We reach a target goal of around 8 milliamps. And that varies based on each patient to patient, depending on their tolerance, any side effects. And we use those windows, those trips they make to the clinic to either up-titrate their GDMT, which they may not be on before, especially in those who are intolerant, or for whatever reason they had a perceived side effect. And we have actually seen that we are able to achieve that quite a bit. So it's really complementary. So we are now using Barostim as a complement to some of the GDMT titrations which were not possible in these patients before. And then at 12 weeks and beyond, we start looking at markers of success. We look at their biomarkers, we look at echocardiogram, 6-minute walk test, as well as cardiopulmonary stress test in 6 months. I'm going to share a few cases with you, examples of typical patients in our practice. This is a case, 65-year-old woman, dilated now ischemic cardiomyopathy, has class 3 symptoms. We look at the VO2 11.7, a steep slope. We went ahead with a right heart cath, and the hemodynamics actually were not terrible, and actually cardiac index was 3. So we said instead of going straight on for advanced therapies, we'll go ahead with Barostim implantation. You can see the medications, they were on pretty good, actually, I would say rather stellar medications, maximal tolerated, despite they had pretty profound symptoms. This is, they underwent Barostim implant in January 2023. We were able to rapidly titrate them up to 9 milliamps beyond our usually target goal, but then because of neck stimulation, we had to reduce it down to an equivalent of 6 milliamps. At 3 months and follow-up, they had improvement in exercise capacity. They still were able to maintain their GDMT, so we didn't have to decrease or anything, and they were asymptomatic and truly asymptomatic at NYHA1. Another one, 47-year-old woman who had peripartum cardiomyopathy, a long duration back, 18 years back. At the time of diagnosis, her EF was around 30-35, which had improved with GDMT over the years, so 45-50, was doing well, and around 2 years back had a progressive decline again. And now she was at EF around 25%. On good therapy, she was adherent, so this is not a case of non-adherence. Persistent symptoms, class 3. Good therapy, except for not being on RAS agents due to documented angioedema. We do a VO2 12.2. Slope wasn't that steep. The ventilator efficiency slope wasn't that steep. We did a right heart cath, index of 0.2, and basically went in for implant and really good results. Now, I know we're running out of time. I wanted to show you the 66-year-old woman who again had a dilated cardiomyopathy. I'm sorry, I was told that the slides won't blank off, but I'll talk about. This is a patient. I really wanted to talk about this because non-ischemic cardiomyopathy, dilated, had a referred to us for Barostim. Looking back, was another center 6 months back in cardiogenic shock. Was offered VADs and transplants, was on inotropes. She refused all of them, was weaned off. 6 months later, despite repeat hospitalizations now, she was referred over for Barostim. We started talking about it, wanted to get stress testing data and right heart cath. Before that, she was hospitalized in cardiogenic shock. Despite all that, she didn't want a VAD or transplant. So she only wanted Barostim as a rescue therapy. And clearly we said no to this patient based on our algorithm. And lo and behold, within a few days, she was progressive cardiogenic shock, biventricular failure, requiring biventricular support. So the point I'm trying to make is to really, stay away from those late-stage patients. Now, we don't have time anymore, but when you put it all together, patients to, again, think about persistent symptoms, low EF. There are CRT non-responders, maybe intolerant to medications, and if you are in an advanced center, you can use those cardiopulmonary stress tests as well as the right heart cath hemodynamic data to guide you a little better. So it's important in closing to really use the window of opportunity, not wait too long, because you're going to lose that window of opportunity. Similar to also utilizing your GDMT early on, not delaying that as well. You don't want to do this therapeutic inertia and kind of massage it out over the year. Really rapid titration of the therapies, and then if there are residual symptoms, consider this therapy. With that, I'll stop here. I'm happy to discuss more in the debate section.
Thank you very much.